right, thank you very much. Well, I'm trying to give you an overview of all kinds of possible tests, because if we tried in literature to compare data, and that's where it all goes wrong. For instance, we lately tried to compare outcome of treatments for DVT. And then you go through the literature and you try to find out which patients are comparable and which groups can be compared and see for which treatment is the best for the patient. And unfortunately, we end up having a meta-analysis which is in fact worthless because we are comparing apples and pears. And that goes through venous disease all over. And what we try to do now is to try to make, let's say, comparable investigations and lists that we can use to compare at least results. And I think at the end of the line, I will tell you at the end, that probably we will be obliged by the healthcare authorities that we have to register a lot of those things to tell us a bit more about outcome. And that they want to have outcome data, and the outcome data will tell you if you have, as an institute, are allowed to do the procedures, or as an individual are allowed to do it, because you have to show your outcome. And outcome should be addressed in one way or the other. And that's where this talk is a little bit about. So what can we try? And what clinical assessment, we try to standardize it. And we are lucky that we have already for a long time had the CF classification, which works nice, but there are pros and cons around it. The VCSS score and the Villalta score are other scoring systems to try to get clinical assessment of the pathology. Then on the diagnostic side, we talked about, Peter Neglin already alluded to the fact that you have so many ways of trying to assess venous pathology, but we don't know how to do it properly. And I think one of the first steps is that we have to better quantify the pathology visualized with whatever method you use, for if you use MRI or venous phlebography or duplex or whatever. And that's where the LET and LOVE score comes in. Of course, all the others say, okay, these are all surrogate outcomes. If you want to compare results at the end of the line, you want to know how the quality of life of the patient is improved. And there you come again in trouble, because there's so many different lists. We have generic quality of life lists, which can be used, and there are, of course, disease-specific ones. And lately, we added to it psychological lists to see for how the psychological impact of the disease is. I know that Alan Davis has written one paper on it, and we are now analyzing around 1,000 patients to see how the psychological impact of the disease is on the quality of life of those patients. For if this is something essential at the end of the line, we don't know yet, but it's something to investigate. And then I will try to come to a conclusion and tell you a little bit about the future. Well, C classification, I won't go into detail here, but this is up till now, in fact, the gold standard on classification of the chronic venous disease. It's published a long time ago. It tells you something about the clinical visible signs. We have etiology, we have the location of the chronic venous disease, and we have the pathology. For instance, in Holland, we use the C, and which we use to say, okay, we have to note for every patient we treat, also for the insurance company, the C classification. What happens now is that the insurance company has said, well, if a patient has C1 or C2, he is not reimbursed for treatment. And they don't give a shit for if there is incompetence or obstruction or whatever. They say C2 is not reimbursed. And that's silly. It's a visual sign of a disease. It's the same as saying, okay, you have pain in your belly, we don't reimburse it. It doesn't matter if you have cancer somewhere or if it's just the flu, we don't reimburse belly pain. Same like headache, we don't reimburse headache. If you have a brain tumor, whatever it is, doesn't matter. And then the other thing gets worse, and they also tell us that if you're gonna treat it, then they say, well, we're not going to treat, and that's one of their reasons that they don't want to reimburse C2, that they say, well, it's only cosmetic, and the other thing, it doesn't show any significant increase in disease. So they state now, okay, we don't treat C2, and they are also considering C3 not to be intruded, and we wait till it's C4. And if it's C4, then we start reimbursing. And that's a little bit silly, because we know that if you treat C2, C3, and you relate to quality of life data, then you can get back from a pathological quality of life to a normal quality of life. If you go to C4, 5, 6, then you can treat whatever it does, but the quality of life will never get to normal again. There will always be an impact on quality of life, also if you treat well a C4, C5, C6 disease. So that's a little bit, if you compare that to oncology, then you say, okay, we're not going to treat any cancers, we wait till there's a metastasis, so we're sure we can't cure it anymore, then we start treating. So there's a lot of debate in Holland about the insurances of healthcare. But the problem is that we use the CEP as a tool to compare data, and now on the other hand we are stuck with the fact that the insurance companies use the C as an instrument to say, well, this is reimbursed care and this is non-reimbursed care. But CEP in the complete version, which hardly ever, nobody uses, that's a good tool, but most of the people use only the C. Well, the CEP is a complete picture. I won't go into detail because I don't have time to go into, but the pro of the CEP is that it's widely used on a routine basis and also scientifically, and it's easy and fast to use, and there's a good inter-observer reproducibility. The poor thing about it is that the con is that you have a poor inter-observer reproducibility, and it's non-sensitive to small changes. If you have C5, whatever you do as a treatment, the patient can be very happy and the quality of life can increase, but it stays as C5. So the corona phlebitis is also something which is not introduced, and we lack, and now we are more in the era of treating deep venous occlusive disease, and we know that venous claudication is something which is out there, but there are no classifications who take care of venous claudication. And also in this system, venous claudication is not included. And of course C3, edema, can be also related to coronary disease, cardiac disease, renal disease, or whatever. So it's not specific for venous disease. So there's a problem there too. So then we have Villalta score. Villalta score is in fact developed to detect post-thrombotic syndrome. It consists of clinical and objective signs and subjective symptoms. It's something which you can give points to, and then at the end you add it, and then you can quantify if you have a mild or a moderate or a severe post-thrombotic syndrome. And these studies are really well documented, and they are a good tool to define for if a patient develops post-thrombotic syndrome. So it's helpful. These are the things how you do it. And there are, so the pros of the Villalta score is that you can use it as both clinical and subjective complaints. It has a good inter-related reliability. It can be used in multiple ways. You can, as in the number, you can have a binary comparison, you can categorical comparison, you can continuous comparison. And it correlates well to the SF36 and venous quality of life. But there are also cons. The intra-rate reliability is not well validated, and we know already in our own experience that it's not too good. If you ask 2 or 3 people to do it, then you come to different outcomes. Then you really have to be trained to do it, and some signs and symptoms like edema, etc., are not specific to post-thrombotic syndrome. And again, that's typical. That's really, in our opinion, wrong. If you look for post-thrombotic syndrome, then venous claudication should be in it, and it's not in it. And that's strange. For instance, if we look at, we did, let's say, 100 treatments on post-thrombotic syndrome and stented iliac tracts, and there are patients with C0, C1, and C2 in it. And if you say, okay, that's and poor Villalta scores, and if you look at that, then you say, well, this is strange that you treat a patient with a stent for an central venous obstruction, but because there is no data on the venous claudication, so you really should put it in. VCSS is again better than on the C development of the C classification. It's further detailed information about the clinical status of the patient and what you see when you investigate the patient, and it's helpful to get more detailed information there. This is the revised VCSS. Well, I won't go into detail, but it quantifies the C of the CF a little bit better. And that helps because if you now have, you treated an ulcer with superficial vein surgery, and then the ulcer, you had first 3 ulcers and big ones, now you go to 1 ulcer and a small one, then you have done something for the patient. But in the CF classification, we still have C6. So C6 stays C6. And that's the VCSS quantifies the C a little bit better and gives you the opportunity to evaluate your therapy a little bit better. So I think that's one of the biggest pros that you can do that. It's assessed many levels. The cons is again that some signs and symptoms are non-specific, but that relates to a lot of things, like edema is again a non-specific sign of venous disease. There can be other causes. Again, venous claudication is not used, and the corona phlebitica is here scored as a mild varicose vein. There is a lot of debate about it. There are publications, especially from the French side. They say, well, the corona phlebitica is something which belongs to C4 and not on the mild stages. But there's a lot of debate, and there's no conclusion on that issue either. Then we have something related to how to quantify venous disease if you look at the morphological things. Well, we have duplex, MRV, CTV, all things, but we don't have a list how to quantify the data collected with those investigations. And again, if we try to look at information on investigations and treated segments before and after, and if you look in the literature, then you end up having, in fact, no information. In fact, you cannot compare it because it's not quantified. So we have to get more precise data. And this should be a list in which you can really, for each segment, tell, is there so many stenosis, so many incompetence, or whatever you want. But you really have to have a detailed list of every segment and do this pre and post treatment in a lot of patients. And if you can collect the data with duplex or whatever treatment you want. And we have compared this with MRV and duplex ultrasound and CTV, and it looks very good comparable. But again, it's just a method to really list and correlate data in literature. And it's not an individual tool for a patient to say this is the treatment you need, but at least it gives us information in the future if you do meta-analysis that you can say, okay, those groups are comparable and we can get better conclusions. So the other thing is that from the LOVE score, that's a scoring system for each segment, you can correlate the LED classification. That's, again, I told you when I started about the deep venous thrombosis, and we try to compare it. We don't know if people talk about central DVT or peripheral DVT or iliofemoral DVT, and one says, okay, that's only above the groin, and the other says, no, it's till the popliteal vein. So many differences. And on a theoretical basis, we made the LED score to be in 4 levels, in which one is calf vein thrombosis, which has other therapeutical ranges. You have femoral thrombosis, and LED score 3. Then the outflow of the leg is completely impaired. So there's a common femoral vein or a higher occlusion. And the reason why we want to have this classification, if you want to treat patients with only the conservative treatment, or you want to do an invasive thrombolysis or a stenting or whatever, then the chances that, for instance, a LED 3 classified patient will have a better outcome of an invasive treatment. So this is why we think if you want to compare in the future data published on DVT, then you want to know in which LED classification they are, and then we can stratify them. And this is a tool which helps, on the other hand, also for the individual patient. If you would have data on the location of which would benefit of another treatment, then the LED 3 patient, for instance, could be selected on the individual basis. This is a patient who can be treated with thrombolysis, and a LED 2 and a LED 1 can be treated conservatively. But it helps also in literature to compare things. But this is not out there yet. We have a lot of data, but we can't compare it. So in our meta-analysis we recently did, we ended up having, in fact, no conclusions. So the pros is that we have a better registration of the pathology in each segment, and we can use it in a physiological way to select patients. That's the benefit of those scoring systems. But of course, they are not yet validated yet. We have to work on it, but those things have to be really registered in the future, like when we started in the 90s, the CF classification. I think we should also start using a LOB and a LED score indeed to be able to compare data in the future. Then we have quality of life. Well, that's a very difficult issue because there's so many different lists are out there. You have, of course, you have the general, the generic, and the disease-specific questionnaires. In the AVVQ, I think the Aberdeen Vein questionnaire is used most, but there are many others out there. You have also the generic, you have the 36, the 12, the Eurocall. Now, I won't go into detail, but the problem is that we have to make a choice. This is, again, there's so many differences out there, and I think a consensus group must be able to come up with a list that's valuable for every patient. If you go to disease specific, it gets worse. Everybody wants to make his own list and has his issues out there. Then you think, well, this is added to it that makes it better, but we don't know which is the best one. So I think the good thing is that we want to have the results related to what the patient feels about. So quality of life is, I think, the only serious outcome which we should measure. But we have so many questions in the quality of life issues that you see they are not significantly influenced by the treatment. So we have to come down to select the questions which really add to it and make the list shorter and easier to use. Because I think at the end we will have to quantify those quality of life scores anyway. So there's a weak correlation between generic and disease specific, but that's, I think, logical. That's for every disease specific. With generic, it doesn't have to change. It changes due to other things. A weak correlation between quality of life and hemodynamic parameters. That's too bad that that's there, but maybe our hemodynamic parameters, like Peter already alluded to, are not the ones that we should measure. We should maybe come up to new measurements, and we only measure subjective changes. Then I just mentioned it, we are now using the hospital and depression scale, the HEAD score, to see if patients have psychological changes. And I won't go into detail there. This is more a thing to investigate. The reason why we started it, that's the only thing I want to say about it, that we thought, okay, you have the patient with cosmetic pathology, you have the patient with real, let's say, physical signs and symptoms, and that we said, well, let's see if the psychological assessment of those complete group would show that the patient who has a cosmetic problem has a more psychological, another psychological, let's say, picture of the disease than the ones who have physical changes. The strange thing about it, I will stop. The strange thing about it is that if we wanted to do in 1,000 patients, we said, well, about 30% will probably be cosmetic. And in an anonymous questionnaire to see how many patients quantify their complaints as cosmetic, it showed that only 3% scored to be pure cosmetic, instead of what we always think, that it's about 30%. So, conclusion, clinical assessment, I think at this moment for the C of the clinical, the VCSS is the best. The diagnostic tool, if you want to quantify what you measure, whatever measure you use, I think the LOB score really segments and gives the right information. Quality of life, the generic, the shortest, the better. That's a short form 12. The AVVQ is the best validated till now, I think. And psychological change, we don't know yet. Why is this important, this talk? I think that in the future we will be obliged to register all those quality of life and things to get reimbursed by the insurance companies, and that we can show that we deliver good quality. And if we don't, we are not allowed to do the treatments anymore as an institution or as an individual. So that's why I think it's essential. Thank you very much.